off with strategy meetings and health input into them. We'll talk about who health are and how health works, because it's a very generic term. I'll look at child protection medicals themselves and the investigations that follow, and then have a look at bruising. And I have got some cases and photographs at the end, and I'll warn you when photographs are coming, just in case, but it is all children that we've seen, and hopefully there won't be anything too distressing.
Too loud for you, or is it all right? Is it all right?
Okay, so strategy discussions, I guess, is the first level of safeguarding once we get ahead of early help and child in need. So it's looking at children who are potentially at risk of significant harm. And it's defined in Working Together from 2018. So whenever there's reasonable cause to suspect a child is suffering or likely to suffer significant harm, there should be a strategy discussion involving children's social care, police, health, and other bodies such as the referring agency. So it's quite clear there that as a minimum, strategy discussions should involve children's social workers, the police and health, as well as anybody else who's relevant. Strategy discussions themselves are quite fluid. It might be a face-to-face meeting, it might be a phone call, it might be a Teams meeting, it may be that there's more than one discussion, and you can have several strategy discussions in a case. So strategy discussions are there to share information, look at the possibility and work around a criminal investigation, and to decide whether inquiries under Section 47 of the Children Act should be undertaken. So that's when you're undertaking a child protection assessment, of which a child protection medical is a contribution. So unless there's a Section 47 assessment being undertaken, a medical assessment isn't a child protection medical, it's just a medical assessment. So child protection medicals are specific to Section 47 of the Children Act. When we're looking at child protection medicals, it's looking for a specialist assessment, not necessarily from a doctor or paediatrician, to make sure that we've looked at appropriate treatment and to follow up health concerns, and to look and see how the child's health or development may be being impaired. It isn't just to look at injuries, and we're required to contribute to the assessment, provide information about the child and family, and potentially whether any investigation may need to speak to a child or a young person without the knowledge of the parent or caregiver, to get their voice, to hear their disclosures, and to look at things from their perspective. After we've undertaken our medical assessments, we are required to contribute the information going on into any child protection case conferences, and anything else that goes forward, and then to take part in decision making in any case conferences. So it's not just about undertaking a medical and telling the social worker what we think. We then have to contribute to any multi-agency meetings that take place following the assessment. It isn't just a one-off couple of hours one afternoon. So when we're looking at health, because health have to be present at a STRAT meeting, health may be a MASH nurse, it may be named and designated doctors and nurses from the local trust or from the commissioning group. We may be thinking about community children's nurses, acute paediatricians, community paediatricians, ward staff, the GP, health visitors or school nurses, midwives, orthopedics, sexual abuse referral centres, or everybody on that list counts as health. And all those professionals have a different role, a different involvement with the child and their family. They all have different training, they all have a different understanding of the situation, and all might have a slightly different contribution to make to STRAT meetings. So we need to be sure that when there is a STRAT meeting, who the correct health professional is, and doing the best we can to have them there so that we can get them the most appropriate health information possible. And it may be that you need somebody who is there who already knows the family, but then you also want someone to be able to contribute to say what should happen going forwards, maybe with more of a safeguarding or child protection training to it, so that they're able to contribute to discussions about future management. When we look at the child protection paediatricians within Walsall, the child protection medicals are done by both the acute and community paediatricians who have specific child protection training. Within Walsall, they're available 24 hours a day, 365 days a year. The community paediatric team will cover from 9 a.m. till 5 p.m. and they cover Monday to Friday, and the acute paediatricians will cover out of hours and weekends and bank holidays. So there's always somebody available through switchboard to discuss about child protection situations. We may have the junior doctors on the ward, and the senior junior doctors are paediatric registrars, and they may do child protection medicals, but with senior supervision. When the community paediatricians are on call, so Monday to Friday, 9 a.m. till 5 p.m, they generally have a clinic on in the morning, which could be anywhere in Walsall. They could be in a special school, they could be in an outreach clinic. So there's no one sitting there waiting for the child protection call or the strat meeting. Because they don't happen every day, and we need to make sure that they cover the other aspects of their work. So they'll have a clinic in the morning, but are available in the afternoon. So at the moment in working hours, child protection referral calls are taken by a paediatric secretary with the details passed on to the on-call consultant, who will either suggest that they're booked in for a medical or to ask the secretary to go back to the social worker for further information. So the secretary will email the on-call consultant with the information to pick up during clinic, because it's really hard if you've got back-to-back patients to be able to find the time then to be able to have those one-to-one conversations about cases. So they will see cases of physical abuse and neglect in the afternoons at the hospital for their medical once the referrals come through. It does mean it's tricky for the child protection paediatricians to get involved in strat meetings, and I think that's going to be something that we're looking at supporting and trying to see if we can make that happen within Walsall going forwards. The community paediatricians, when they're on call during the day, so as a team, they're based at the Manor Hospital, but as we've said, they do clinics across the city, including special schools, and their areas of expertise are in developmental delay, ADHD, autism, tic disorders and other neurodevelopmental conditions, physical disabilities and learning disabilities. So that's the bread and butter of their work. When they're in work, they have access to the hospital electronic health records, and that's called Fusion. But there's limited information available to them there. So they'll have access to letters from previous clinic attendances. They'll have information about previous emergency department attendances, and they'll have blood results and X-ray results. What they can't see on the computer is current admission notes, because they're paper records that are kept on the children's ward. They can't see the maternity or the neonatal notes because they don't have access to those systems. They can't see the health visitor or school nurse notes because, again, they're on different systems, and they can't see any GP information. Equally, midwives and neonatal consultants can't see information from others, and neither can the GP. So there's lots of different health professionals who have access to different bits of health information, but very few people have access to all of it. In fact, nobody will have access to all of it. The acute paediatricians are based in the hospital and walk on the ward with the acutely unwell children. So the children who are in with sepsis, who are in with seizures, who are in with asthma, or any other acute medical problem, it comes under the care of the acute paediatricians. All the acute paediatricians, along with all the community paediatricians, have specific level 3 safeguarding training. and the acute paediatricians work in shifts. So there's always a consultant on the ward 24 hours a day, but that means that if someone came in overnight, the consultant who saw the child overnight won't be available today and may not be available tomorrow to talk to anybody, but they will have made notes and handed over that the staff on the ward today can see. But the staff on the ward today won't have had the same experience with the child and the family. And I'm sure you know that there's a hierarchy of doctors on the ward. So the consultant is the fully trained paediatrician who has undergone a minimum of 9 years of paediatric training after leaving university. So that's 14 years of medical training altogether. Sitting below them are the junior doctors, and you're a junior doctor or a trainee up until the point you become a consultant. So the senior junior doctors are in their 3rd to 7th year of specialist training, and they're all training to be paediatricians. But below them, you've got other junior doctors, your SHOs, who are sometimes called ST1s or ST2s, and they're the middle grade. Some of those are in their early paediatric training, others are getting their paediatric experience to go on to be GPs, others may be training to work in A&E or anaesthetics and getting some paediatric experience in there. So just because they're working on the children's ward, it doesn't mean that they have a lot of paediatric experience or that they're even going to be paediatricians in the future. And below those, you've got your newly qualified doctors who do 6 rotations of 4 months each over 2 years in any specialty, and they may end up as anything. They could end up as gynecologists, they could end up as pathologists, they could end up as orthopedic doctors, or they could end up as paediatricians, but they get a wide experience of as many specialties as they can in their early training. And you can't tell by the age of someone how experienced they are. You might get late trainees. You might get people who go into paediatric training or medical training as mature students. So the age or appearance of someone or how experienced they sound when they're talking doesn't actually reflect necessarily on their training or their seniority. So it's always worth checking if you're in a strategy meeting who you've got and what level of training they're at, because different levels will have different experience. When we look at other members of the health umbrella, if we think about the MASH nurses, these are safeguarding specialist nurses. They can see the maternity and neonatal notes and the electronic paediatric notes, but not current inpatient notes. So if it's a child who's currently on the ward, they can't see what the doctors and nurses have been seeing and doing with them. The MASH nurses can see the 0 to 19 service notes, and they should be able to interpret and risk assess from the available information. So not just read off the screen for what's happened, but interpret that relevant to whatever the concerns are. But they don't have any child protection medical experience. They don't have any experience of undertaking Section 47 medicals, so they won't necessarily understand the benefits or otherwise of undertaking a medical. Then you've got your health visitors and school nurses, your 0 to 19 service, who historically have had lots of contact with the families, know them inside out and know what's happening and what concerns there are. But things have changed a little now, and for health visitors, the majority of children are only seen 3 times by a health visitor. So you have a statutory visit in the first 2 weeks at about 9 months and about 2 years of life. And otherwise, there's no requirement at all for a health visitor to see a child. So they do know the children and families where there's concerns with their health or their development or safeguarding. But if you're coming to a family where there's been no previous issues, no previous concerns, and the child is 18 months, the health visitor may have seen them twice and may not have seen them for 9 months or more. So they're just going to be going off records as well. And it's similar for the school nurses. Children should be seen at school entry, in year 6 and before leaving school. And although the school nurses will be in the school and around and available, they don't necessarily see the children and the families any more often than that, so might not have an in-depth understanding and knowledge of the family beyond what they've got in their records. When we're looking at staff on the children's ward, these include qualified and unqualified nurses and administrative staff, and their titles can sound impressive, but again, it's worth checking what their role and their seniority is. We've certainly in other parts of the Black Country had issues with the patient flow manager, for example, taking part in strategy meetings without being questioned, but that's just an admin junior whose job it is to chase up people so that patients can be discharged from hospital and their beds can be released for new patients. And they have minimal safeguarding training and absolutely no child protection expertise, but they looked and sounded professional and qualified, and no one questioned them in strategy meetings, even though they have no health training whatsoever. So it's always worth knowing exactly who you've got at your strat meetings and making decisions around safeguarding. When it comes to the child protection medical, as we said, this forms part of the Section 47 investigation. The child protection medical has 2 purposes. The first one is the health and well-being of the child, to make sure that they are healthy, and if there's any unmet health needs, to investigate and treat them and follow them up as appropriate. So that's one of the hats, is to work as a paediatrician. The other hat is more of the forensic hat. So we're looking for evidence which will support or refute any allegations or disclosures, and highlight any additional concerns. So if a child comes in with a bruise on one arm that you're looking at, it may be that you find bruises elsewhere, or if the child comes in where you're thinking about physical abuse as a possibility, you might identify neglect or other things as well. So it's looking to confirm what's already been suggested, or say, no, this is entirely appropriate, this isn't child protection at all, and it's also to look for any other problems that would be worth investigating further. When we're doing a child protection medical, it needs to be focused on the child, so it needs to be child friendly. It needs to be a single examination done by a doctor who's trained to do it in a place that is appropriate at an appropriate time. A child protection medical is not an urgent medical. It may be that if they've come in with a health need, the health need is urgent, but the child protection medical itself isn't. But it should be a one-stop history, examination, investigations, and photography. So there shouldn't be any need to do a child protection medical at 3 o'clock in the morning. It would be far more friendly for the child and the family and the doctors to do it at 9 o'clock in the morning, or 10 o'clock in the morning, or even the following afternoon. But if they have acute medical needs, they clearly need treating at that time. We can't undertake a child protection medical without consent, and that's very clearly written in law, and it's highlighted by the General Medical Council, the Royal College of Paediatrics and Child Health, the Faculty of Forensic and Legal Medicine, and others. So without fully informed consent from someone with parental responsibility, any examination could constitute assault. It isn't needed for the welfare of the child, it's purely being done to provide information for safeguarding. And if a medical practitioner undertakes a child protection examination without consent, they can be prosecuted, struck off the medical register, and be discredited in court as a very minimum. So we need to take consent for taking a history, documenting what's said, examination, documenting examination findings, taking any investigations, and information sharing following the assessment. And all of that constitutes the child protection assessment. There's no point in us doing it if we then don't information share afterwards. Consent can be given by anybody with parental responsibility, or by the child themselves if they are able to, if they are competent. If the child has significant injuries, they can be treated without consent, and because we can do that in the child's best interests, but we can't take it any further at that stage. So when we think about parental responsibility, it's important to know who has it, because if we try and take consent from someone who doesn't have it, then we haven't got consent and we risk the same outcome. So mum will always have parental responsibility, and dad will if he's on the birth certificate. If he's not, he has no parental responsibility unless he's an adopted parent or he's acquired it through the courts. The local authority may have parental responsibility if the child is on a care order, but they won't have it if the child is on Section 20 or on a PPO, a police protection order. Foster carers are unable to give consent. They don't have parental responsibility, and the police, even if the police have removed the child on a PPO, the police don't have parental responsibility. Step parents don't have it, grandparents don't have it, or siblings or other relatives, unless they've gone through the courts and it's been granted to them. And teachers and carers and others may not have it, although teachers may get it as delegated consent if they're taking the children away, for example, on a school trip for a week. Occasionally, they do ask for the ability to provide consent in an emergency situation, but I'm not sure that teachers would want to give consent in that situation for a child protection medical. Some children are competent to consent, and this isn't age-based, but is down to their ability to understand what's happening. So it tends to be older children, generally teenagers, so they have to be able to understand the advantages and disadvantages of having a medical assessment and the consequences of having a medical assessment. So the advantages and disadvantages would be looking at their health, looking at their well-being, looking at the injuries and sharing safeguarding information to protect them. But it might also mean that parents, that they're removed from their parents, that their parents are taken to court, that their parents end up in prison, that they end up in foster care or looked after by somebody else. So to be able to give consent, they have to have that understanding. But they also have to be able to understand the consequences of not having the medical assessment as part of the child protection medical. And they shouldn't be pressured into giving consent for themselves. So you can't have a police officer sitting there saying, look, we can do this the easy way or we can do this the hard way. We're going to do the medical. If you don't give your consent, we'll go to court and they will give consent on your behalf. You might as well just sign the form. Doesn't count as valid consent. That's coerced, and we can't do that. And I'm sorry to pick on police officers on that one, but it has occasionally happened to me, though not for some time. When we're doing the medical, clearly the child and the doctor have to be present, but there should also be a chaperone. In Walsall, this is usually a nursing team member, and they're there to look after the welfare of the child, to make sure that what's done to them is safe and fair, and to make sure that they are happy and to be the voice of the child if the child doesn't feel able to speak up for themselves. We might also have a parent in there or a social worker in there. It's ideal to have both, maybe not in for the actual physical examination, but certainly for while we're talking and undertaking the assessment, and for feedback afterwards. And it's always good to have a police officer present for the security risk, because it is quite a vulnerable thing to be doing. And we might have anybody else as appropriate. So if the child or family aren't English speaking, then having an interpreter who isn't a family member present. We might have siblings present. If it's a sexual assault examination, previously we'll have had forensic medical examiners present, but the child has to be comfortable with whoever's there, and they are the most important person to keep happy at this time. So you might find that if you're a professional coming along to child protection medical, we do ask you to leave us for the examination. So during the assessment, we will ask lots and lots and lots of questions. So who's the GP? Which school do you go to? Who's in your family and who's in your house, because they're not always exactly the same, and any health problems that run in the family, because this might have an implication for this child, or any injuries or findings that we have. We want to know about this child's current health, any medication they're on. We know that anti-epileptics can affect blood clotting, so that can affect bruising, just as an example. So we need to be aware of that. We want to know about the child's immunisation status if we're thinking about neglect. And the same with medication. Do they collect it regularly? Do they have it every day? We want to ask about allergies, and we need to know about their neonatal history, their past medical history, and their level of development. Are they where you'd expect them to be? Are they delayed? If they do have any disabilities, will this impact on their mobility or their ability to understand, the level of supervision they need, and that kind of thing? We need details of the allegations, because then we can put any examination findings into context. We look at the state of hygiene of the child and the appropriateness of the clothing. We look at the interaction of the child with carers, siblings, nurses, doctors, and reciprocated. And we'll do a brief assessment of their development, even if it's only watching what they do, listening to what they say out of the corner of our eye while we're doing the discussion with professionals and with parents. We'll still be looking at and watching the child. We'll do a normal physical examination, so looking at the heart, lungs, abdomen, ears, nose, throat, just like going to see a routine medical examination. And then we'll do a full inspection from the top of the head to the bottom of the feet for any injuries, evidence of previous injuries, evidence of neglect, and absolutely everything gets documented in our document file. Following the examination, we might need to think about doing investigations. So this will depend on the clinical findings and what the story is. So we might think about doing blood tests, and there's a huge number of blood tests that we can potentially do. The ones we would do most commonly would be to look at clotting. So if somebody's blood doesn't clot very easily, they may be prone to easy bruising. Most people who will say, oh yeah, he bruises really easily, most of those children will have completely normal clotting, and there's no underlying medical problem. We might also look at vitamin D levels, if there's a poor diet, or if you've got an Afro-Caribbean or dark-skinned child in front of you with a fracture, for example. Low levels of vitamin D can predispose you to easy fractures. And blood counts is looking around neglect as well, and iron stores. So if you have a diet that's deficient in iron, which comes from meat, green vegetables, and fortified foods, then you might be worried about anemia. But there's a huge number of tests we can do, so we can add onto that and change things around if we need to, depending on what we find. We might take an individual x-ray of a bone if we're worried about a fracture in an older child, and I'll talk a little bit about skeletal surveys on the next slide, I think. In infants, we might do a CT scan of the head, and we need to be really careful with children when we're doing skeletal surveys and CT scans, because it is a reasonable dose of radiation, so we can't just do everybody. We might ask ophthalmology, who are the eye specialists, to come and see. We might take forensic swabs, not just in CSA medicals, but we can take forensic swabs from bites, and sometimes other injuries. And STI screening, it might just be a urine for chlamydia if you've got a 15-year-old who's come in and you're worried about exploitation, even if they've come in with injuries. We can do STI screening as well, or they might not need any investigations at all. So I did mention skeletal surveys, and these is a series of x-rays that we take when there's concerns about physical abuse in a child under the age of 2. They may need sedation for it. You need 2 x-ray specialists, 2 radiologists, and a nurse to go with the family for them, and it can take an hour or so to get all the x-rays. And the purpose of it is to look for previously undiagnosed bone injuries, which is why we only do it under the age of 2, sometimes slightly older if there are developmental impairments. But over the age of 2, it should have been noticed, or the child might have been able to explain if they potentially had fractures or pain or anything else. Babies, it's very easy not to notice fractures, infants and that sort of thing. So it's to look for previously unnoted fractures. So we take 2 sets of x-rays of every single bone in the body, 10 to 14 days apart. And we do that because the x-rays that are taken immediately might not show any injuries that have recently occurred, because it's the healing new bone that takes a few days to appear that shows at best on the x-rays. So your first set of x-rays is to look for previous injuries. Your second set of x-rays 2 weeks apart is to look for any injuries that might have occurred at the same time as the injury that's come to light, and set off the whole child protection medical process. When we've got those x-rays, they have to be seen by an x-ray specialist at the Manor Hospital. He or she may have paediatric experience, but they're not exclusively paediatric trained. So they're then reported on by a paediatric radiologist at Birmingham Children's Hospital, Carl Johnson, and he is paediatrically trained and child protection trained. So he can only do that after the second set of x-rays has been reported on locally. So it can be 3 weeks or so after the child protection medical before we get that back. And as Carl Johnson's the only paediatric radiologist at Birmingham Children's Hospital, if he's on holiday when the x-rays arrive, it may take longer. And it's just to remind people that normal x-rays don't mean that no abuse has taken place. It just means the child's lucky enough not to have had any fractures. It doesn't mean that the bruises that have been seen previously aren't important. It just means that there's no evidence of bony injuries, but it doesn't exclude the possibility of abuse and previous other injuries, just not fractures. We also try and take photographs of all injuries. So the hospital has a photography department, a medical illustration department, and they will provide cover 24 hours a day, 365 days a year. They're child friendly, they're child protection trained, and the police will often say that the photographs they take are of a better quality than the ones that their forensic SOCOs will provide. So that they are forensically trained and really, really good. They cover both Walsall and Wolverhampton. And you can ask them to photograph injuries. You can ask them to photograph evidence of neglect. If you have an alleged implement, they can do that. If you have a bite, you can take serial photographs of the bite from them so that that can be looked at by any specialists. You do need separate consent from someone with parental responsibility to take the photographs, and there is an extra level of consent we can ask for to be able to use the photographs for teaching. So any photographs that I've included today are from patients that I've seen with consent from the family to use them for teaching purposes. The photographs stay in the clinical notes, but may be used in peer review and may end up in court if police or social care apply to the hospital for copies of them. Okay, so coming on more specifically to bruising. Bruising is skin discoloration that arises from blunt force trauma. So it doesn't come from anything sharp that cuts the skin. It comes from something hard hitting the skin and damaging the blood vessels below the skin, making them leak with different amounts of blood depending on the situation. When the blood that leaks pools under the skin, the discoloration shows through the skin. It can appear black, blue, purple, brown, yellow, red, almost any colour under the sun, or combination of them, depending on the stage of resolution. So the body will break the blood down, and as it does so, its composition changes and its colour changes, and it does go through a pattern, but you might not always see it. Collections of blood can track between tissues due to gravity. So if someone gets a bump on the forehead that's quite significant, with gravity the blood can track down and it can pool below the eyes, so you get two black eyes from a bump on the forehead sometimes. So we need to be aware when we're doing examinations that where you see the bruise isn't necessarily where the impact occurred. And bruising can also show the outline of an implement that's made impact. So in a slap mark, for example, where the fingers hit the skin, the blood gets forced out underneath here and gets forced into the gaps between the fingers. So you won't see bruising where the fingers made contact with the skin, but you will see bruising in between places where the blood's been forced out of the tissues, and that's where it's settled. And the appearance of bruising is affected by the underlying tissue. So if you thump someone on the stomach, it's harder to get a bruise than if you thump someone on the forehead. The bone under the forehead acts as a stop in there, so it's easier to compress between your hand and the bone of the forehead, and you get much easier bruising than if you're punching onto something soft like the abdomen where there's nothing to get purchase against. So that's always worth bearing in mind when we're looking at bruises. It varies with the force involved, so something big and wide and flat will produce less of an impact than something small with a lot of force. And the direction of impact can play a role as well. So if you're going across the body and it's almost a shearing force, so you've got a bit of friction in there as well, you can get a different type of bruise to if it's directly into the body at 90 degrees. And bruises can also very heavily be influenced by an individual person's characteristics and health, medication we've already discussed, and that sort of thing. So bruising is the most common injury in children who've been abused, but it's also the most common injury in children who haven't been abused, apart from pre-mobile infants, where you tend not to get accidental bruising. To bruise accidentally, you have to be able to hurt yourself accidentally, and you can't do that if you can't crawl or roll or walk. We know that the number of bruises a child sustains through normal activity increases with age. So a toddler may have 1 or 2 bruises. A 6-year-old who's running around playing rugby in the playground will have more bruises. And then once you get into adolescent years and you're a bit less clumsy and maybe you run around and fall over less or climb trees less, you will have a tailing off in the number of bruises that you have. But we do know that children who play football, people who do judo, and other sporting activities can also give you more bruises as well. So we also know that in cases where bruising has been the first injury that's been noted, and child abuse hasn't been known of before, it's really important that we recognise that so that we can get involved with these children early and prevent any serious abusive injuries or death later on. And it's also important to remember that accidental bruises can be evidence of neglect. So if a child comes in and they're covered in bruises, but there's nothing about them that's suspicious in terms of their location, their size, their shape, or anything like that, but it's just a sheer number of bruises, that could be medical from a clotting problem, or it could be a lack of supervision within the family, or that they're allowed inappropriate play, or that the home isn't safe for them, and that could be seen as neglect, and we might find other evidence of neglect as well. So we're not just thinking physical abuse when we see bruises, we're thinking of neglect as well. So when we're assessing them, we're looking at the size, the location, the shape to see if there's any repeated patterns or typical patterns, and that can help us to decide if they are inflicted or accidental injuries. We can look at the developmental stage of the child. If the child is unable to walk, then they're going to be unable to fall over and bruise their knees and shins potentially. We need to look at the allegation that was made and to see if the injury fits in with that or if it fits in with another explanation. And when we look at bruises, even though they go through a standard pattern of colour change, we still can't say how old they are, whether they're fresh or not. We can't say when they occurred, and if a child has several bruises, we can't say whether they were caused at the same time, and we can't look at a bruise and say who inflicted it. So that's questions that we can't answer. In terms of timing of injuries, the only things we could potentially say is if there's any swelling or tenderness with the bruise, that tends to be evidence of a more recent injury, but we still can't put a time on it. And if we try to do that, we'll be discredited in court and our evidence won't be of any use whatsoever. What we can usually say is whether the explanation given is plausible given the injury that we've got in front of us. If there is significant bruising, we can look and see if there's an underlying health problem that means they bruise easily, but that's not to say that children who bruise easily don't get assaulted. So we still need to bear that in mind, that even if the injuries we see are due to a medical underlying condition, they may still have been abused to have got them. So we still need to keep that in the back of our minds when we're looking at them. When we look at the literature, it explains that bruising to the ear, to the face, the neck, the body, and the buttocks is significantly more common in abused children. But it doesn't say it doesn't happen accidentally. So we can't say that every bruise to the ear, every bruise to the face, every bruise to the buttocks is abuse, because sometimes it's not. And there's no cutoff. We can't say that 90% of the bruises are in abused children and 10% are in non-abused children, and there'd be no way of knowing which was which. So we have to look at each bruise in isolation and in context with the history in the child. We also know that abused children have significantly more bruises in all regions except the legs. But again, there's no cutoff. We can't say if you've got 4 bruises on the arms, then that's abuse. If you've got 3 bruises, it's not abuse. We just know that abused children have more bruises. And it's the same with the size of the bruise. Apparently, bruises in abused children are larger than in non-abused children in all regions of the body, but there's no cutoff. So nothing is 100%. We can't say, well, he's got a big bruise on his abdomen and 3 bruises on his legs, therefore it's abuse. But it's just what we've got to have as we're putting everything into context with the history, the child, the family, the medication, the health problems, and what we're seeing and learning. We know there's no difference in bruising characteristics between boys and girls. And we do know that most, but again, not all, accidental bruises occur over bony prominences and are commonly seen on the front of the body. So if you think about your child who's in the playground, who's going to fall over, they'll get the knees, they'll get the shins, they may get the hands as they put their hands out to rescue themselves. They may get forearms as they land on their arms. They may get their nose or their forehead. It's harder to get accidental bruises on the back of the body, but not impossible, and nothing is ever 100%. So we can't look at a bruise in isolation. It needs to be looked at with the medical and social history, the development of the child, the explanation that has been provided. Sometimes there's more than one. The child may say one thing, the family may say another. We need to take into account our full assessment of the child and any tests that we've done. We know that bruising in children who are not independently mobile is suggestive of physical abuse, but it might not be. We know that bruises seen away from bony prominences are suggestive of abuse, but might not be. We know that bruises to the face, abdomen, arms, buttocks, ears, neck, and hands may be suggestive of abuse, but might not be. Multiple bruises in clusters might be suggestive of physical abuse, but there could be an innocent explanation. Multiple bruises of a uniform shape. So if you've got the same shape in different places, in terms of bruising, then that might indicate that the child's been assaulted with an implement, but it might not be. Bruises that are the shape of an implement, so it might not just be clusters or multiple bruises, it might just have been a one-off, maybe with a slipper or a shoe or a wooden spoon or a stick, then that's more likely, but again, it might not be, although you'd have to have a much better explanation. And bruises that are accompanied by petechiae, which are tiny pinpoint red bruises. If there's no underlying bleeding disorder, then the presence of both a typical bruise and petechiae together is suggestive of physical abuse, but again, it might not be.